Thank you all so very much. It is such a privilege and pleasure to be here with all of you. And I have to say, I never need an excuse to come back to Texas. So I was joking with Leah and Janet that I've been in Michigan for 4 years now, but my cell phone is still a Texas number. So they are right. I'm still a Texas girl at heart. I'm from Midland, Texas. And so I'm happy to be in my home state. And it's really a privilege and a pleasure to be with all of you, because I have to confess that I think I'm going to learn more from you guys than you will learn from me. And when I think about how we support the needs of infants, toddlers, children, adolescents, and adults with suspected fetal alcohol spectrum disorders, it is really a collaborative effort. It is really a team effort. So diagnosis, which is really the majority of what I'll be talking about, is, and then a little bit about how to support the needs of individuals with the diagnosis. Diagnosis is just the beginning. And so I really see that in creating systems of care, in addressing the needs of individuals who have been affected by alcohol, and to address those needs for them throughout the lifespan, it really requires a very thoughtful, collaborative approach of people from multiple disciplines. We're going to talk about lots of different things over the next 2 hours or so together. And basically, I have to confess, I have a little condition called PowerPoint-itis, which means the slides that you have are mostly the slides that I'm going to present, but of course, in sort of the last-minute PowerPoint-itis diddling world, I've updated the slides a little bit. So the beginning part, the historical perspective of fetal alcohol, is something that is not a part of your slides, but I'm very happy to send Janet and Leah a complete copy of this version of the slides for your use if you're interested. So over our time together, I'd like for us to present a historical perspective of FAS. We're going to review the revised Institute of Medicine diagnostic criteria for fetal alcohol spectrum disorders, FASD. We're going to review the evaluation of FAS facial features. And really the purpose of this is not to make us diagnosticians, but really for us to be aware. Because I'm very aware that in the multiple settings in which you all are involved, you are often the first line. And so you will see these children because they have developmental differences, because they have behavioral vulnerabilities, and it's only when you are aware of some of these sentinel facial features can you begin to plant the seeds in others' minds, the minds of the parents, the minds of the other professionals who interact with these children, to say, there's something unusual about this child. I wonder whether this spectrum of difficulties that this child is exhibiting might be explained by an underlying fetal alcohol spectrum disorder diagnosis. And you can make that leap if you are attentive to some of the presenting signs of FASD. So that's why we'll spend a little bit of time talking about what these sentinel facial features are. We'll talk about the effects of intrauterine alcohol exposure on the developing brain. And then just so that we can end on a note of hope, I'd like for us to talk about some opportunities to promote resilience in children with FASD. Thinking that this idea of intervention in children who have been alcohol exposed is still it's still a field really in its infancy, and there's still a lot more work and a lot more research that needs to be done. But we can at least start to think collaboratively and creatively about what does the research from other child development disciplines tell us about working with infants at risk, and how can we apply it to this population. So I'd like to start our talk by going through sort of an overview of 40 years of fetal alcohol. Yes. Oh, I'm just blocking the screen. So so first we're going to talk about 40 years of fetal alcohol syndrome. And so I'm reflecting that this is a really young diagnosis. And so I imagine that this diagnosis and this condition is younger than perhaps some of us here in this room. And so there is a lot that we don't know about this condition, but yet in the last 40 years there's a tremendous amount that we have learned. Thinking about the idea of alcohol as a teratogen, it's been well known and well described for centuries that alcohol has detrimental effects on the developing person. Even as far back as Aristotle, and said, "Foolish, drunken, or harebrained women most often bring forth children like unto themselves." And then in the book of Judges, behold, thou shalt conceive and bear a son, and now drink no wine or strong drink. So it seems centuries ago we have had an awareness that the effects of alcohol on the developing fetus are problematic. Yet it has taken centuries for us to really unpack the effects of alcohol on the developing person. So the first studies that we know of that have explored alcohol as a teratogen date back to the 1700s. And from the Royal College of Physicians in London, there was an investigator who noted that children of alcoholic women were described as weak, feeble, and distempered children who must be, rather than being an advantage in strength, were rather a charge to their country. So even as far back as the 1700s, 300 years ago, there was a sense that children who have been prenatally alcohol exposed have developmental, behavioral, and differences that are apparent through the lifespan. And it was over 100 years later when sort of this line of research and investigation was continued. And the deputy medical officer from the convict prison in England, Dr. William Sullivan, did a study of 600 offspring of imprisoned alcoholic women. And he noted that these children of alcoholic women had a higher infant mortality rate. Many did not live until their second birthday. And those who did live, those who did survive, were, in his words, noted to be not productive members of society. And from his observation of these 600 children, he concluded that alcohol had a direct toxic effect on the embryo. And so, of course, we know that now, but it was really many years and actually into the 20th century before this idea of alcohol as a teratogen on the developing embryo was actually explored in the medical literature. So the first documented history in the medical literature was back in 1968 in France with Pierre Lemond. And he wrote a paper describing 127 children of alcoholic parents, and he described the physical anomalies and the behavioral vulnerabilities and the behavioral differences in this cohort of 127 children in France. So even though this is the first documentation of the effects of alcohol on the developing fetus, and even though it was done in 1968, that work never sort of took root and opened sort of our door to thinking about FAS until 5 years later. So 5 years later, Ken Jones from the United States wrote a series of 3 seminal papers in The Lancet that described the effects of alcohol on the developing brain. The first, in this series of 3 papers, he talked about this pattern of malformations in the offspring of children of alcoholic mothers. And he was the first person to delineate systematically the association between maternal alcohol abuse, so the effects of heavy alcohol use, and a specific pattern of birth defects associated in these children of alcoholic mothers. And he was the first person to describe and provide a diagnostic criteria for this condition. And so I'd like to tell you a little bit about the 3 landmark papers of Dr. Jones. So the first one was, all of these 3 papers were in the Lancet, which is really one of the highest tier medical journals. His first paper was Recognition of the Fetal Alcohol Syndrome in Early Infancy. And in that paper, it established that maternal alcoholism can cause serious and aberrant fetal development. And I'll talk about some of the fetal anomalies he delineated in that paper. His second paper was Patterns of Malformations in Offspring of Chronic Alcoholic Mothers. And in this paper, he introduced the term fetal alcohol syndrome, so really he was the first person who defined this as a syndrome. And he introduced the term ARBD, or alcohol-related birth defects. And then in his third paper, 1 year after that, he talked about outcomes of offspring of children in alcoholic women. Again, another paper published in The Lancet. And so what he found in a retrospective chart review of 55,000 cases, he identified 23 women who were chronically alcoholic, and of those 23 women, he ascertained that 6 children of those 23 actually had the full spectrum of fetal alcohol spectrum disorders. And so in his landmark paper, he articulated and described this unique pattern of malformations seen in children who we now define or describe as having fetal alcohol syndrome. So in his first paper, he looked at these 11 children and he found this unique constellation of symptoms that were characteristic of these children. They all had growth retardation, 100% of them. They all demonstrated developmental delay and mental deficiency, and they all had this characteristic pattern of craniofacial abnormalities. And so when we think about the sentinel characteristics that are required for fetal alcohol syndrome diagnosis, it's really these three symptoms or these three characteristics that are really the underpinnings of our diagnostic criteria. He found that many of these children had maxillary hypoplasia, so flattening of the midface. They had many of them had joint and palmar crease abnormalities, and many had cardiac abnormalities.
What was the next to the last one?
The joint and palmar crease abnormalities, so abnormal creases in the hand. So we will get to that. And so since this syndrome was identified and named back in 1973, there's really been an evolving terminology of how we understand children who have alcohol-related disorders. So in 1973, Ken Jones first coined the term fetal alcohol syndrome. And then in 1978, the term fetal alcohol effects was used, or was coined by Claren and Smith. And that was their way of describing children who had partial expression of the syndrome, that there were some children who were alcohol exposed who didn't seem to have the full constellation of symptoms. However, this term fetal alcohol effects, as you may or may not know, was really open to some controversy. It wasn't very well defined. It didn't really describe with precision what these effects of alcohol were. So almost 20 years later, that term FAE, fetal alcohol effects, was a terminology that was actually discontinued. Building on that, wanting to define and have a more precise nosology, a more precise nomenclature for how we understand the effects of alcohol on the developing person, the Institute of Medicine came up with these different diagnostic categories back in 1996, which we know today as FAS, fetal alcohol syndrome, PFAS, partial FAS, ARBD, alcohol-related birth defects, and ARND, alcohol-related neurodevelopmental disorder. And then in 2003 came the term that we are all familiar with, fetal alcohol spectrum disorders. So the big umbrella term that encompasses all of these. And so when we think about over the last 40 years, which I think is really incredible, 41 years ago, we had no term for FAS, for fetal alcohol syndrome. And now, 40 years later, over 3,500 papers on FASD have been published, and that number might even be an underestimation of the research that continues to evolve. And so where we are right now, 40 years later, is I can say, things are, there's a combination of the light and the shadows. And so the light is that we have greater awareness. We know that alcohol has detrimental effects on the developing person, and we can better quantify those effects through our different categories and our diagnostic classification systems. But the shadows, the conundrum that we're faced with 40 years later, and I think this is where the field needs to grow and perhaps unify and integrate, is in how we diagnose and how we identify children with who have been prenatally alcohol exposed. So there have been several diagnostic classification systems that have evolved since FAS was first identified, and most of them are still in use today. So in 1996, there was the Institute of Medicine criteria that I described for you. In 2000, colleagues from the University of Washington came up with their classification system, which is commonly known as the 4-digit code, that was developed by Susan Astley and Sterling Claren. In 2004, the CDC came up with their own criteria for fetal alcohol syndrome, so not the other FASDs, but just fetal alcohol syndrome. In 2005, our colleagues from the North came up with the Canadian guidelines, and that was Albert Chudley. And also at the same time, those initial original Institute of Medicine criteria were revised and that was by Jean Hoyme, and that was also in 2005. And so I'm going to spend a little bit of time talking about these different diagnostic classification systems, because I think this is where there is, I think this is what is really a challenge for the field, is that depending on the classification system you use, there can be, a child can either meet the diagnosis or meet the criteria or not. And so that makes it challenging. So in 1996, the Institute of Medicine came up with this diagnostic classification system, and they described 5 patterns of anomalies. So FAS, with or without alcohol exposure, partial FAS, ARBD, alcohol-related birth defects, and ARND. So that was a real strength of this system. They came up with several criteria for how you make these diagnoses, which include some pattern of growth deficiency, which was not well described. They said, well, probably low birth weight or low weight per height or a decelerating weight trajectory over time. So there was a descriptor, but not really defined cutoffs as what constitutes sort of low birth weight or affected weight. They described that children with FAS have a characteristic pattern of facial features, which were described as short palpebral fissures and possibly flat upper lip and a flat philtrum and possibly a flat mid-face, and could include any combination of these. So again, the quality of those facial features is not quantified, and how many of these facial features you need to meet the diagnosis was not really well articulated. In terms of CNS or brain deficits, the original Institute of Medicine criteria said small head circumference at birth, some abnormal structure, or some neurological hard or soft signs. Again, how small does the head circumference need to be for us to consider this as an FAS? And then the other criteria was prenatal alcohol exposure, excessive or unknown. The advantages of this classification system was that it was easy to use, nice, clear categories, and it described these spectrum of deficits and aberrations of FASD-related conditions. The vulnerability of this diagnostic classification system was that it was really vague. The deficiencies were not well quantified, and the levels of cutoff were not very well defined. So building on the vulnerabilities of this system, Susan Astley and Sterling Claren came up with the University of Washington criteria, or what we know now as the 4-digit code. Their diagnostic categories are a little bit different than what the Institute of Medicine came up with. They describe a pattern of effects called fetal alcohol syndrome, partial fetal alcohol syndrome, and then they describe 2 other categories that are not part of the Institute of Medicine: static encephalopathy alcohol exposed or neurobehavioral disorder alcohol exposed. So slightly different nomenclature. They have very similar criteria that they've tried to define a little more precisely about what quantifies levels of risk. So in terms of growth deficiency, they define it as height or weight at any point in time, prenatally or postnatally, less than the 10th percentile. They describe a pattern of facial features, and they require all 3 facial features for full FAS. And they define very tightly how big the eyes should be. So PFL is the palpebral fissure length. We'll talk a little bit more about that. And they say in the Washington criteria that the eyes have to be less than the 3rd percentile, and the lip and the philtrum have to be either a 4 or a 5 on their lip philtrum scale. And we'll talk a little bit more about what that looks like. They talk about different parameters for what is described as CNS dysfunction, either microcephaly, which they described as head circumference less than the 3rd percentile, some characteristic of abnormal structure, hard neurologic signs such as seizures, hemiplegia, or some pattern of CNS dysfunction, which they grade on a 3-point Likert scale, 1, 2, or 3, in terms of neuropsychological function. And again, like the other systems, they quantify prenatal alcohol exposure, confirmed or unconfirmed, and they also quantify the amount of alcohol on a 4-point Likert scale. The pros of this system is that it's widely published. They rank the neuropsychological features, they rank the alcohol exposure, And they have been very generous in terms of sharing and widely disseminating their classification system, and in the training of their classification system. They have online training courses that are available, and those training courses are free. So it makes it a very accessible way of becoming trained in the diagnostic criteria. The challenge of this system is that it doesn't include ARBD and it doesn't include ARND. And so when one has a diagnosis of static encephalopathy, alcohol exposed, or neurobehavioral disorder, alcohol exposed, there is a little bit of a dance to determine, well, does this pattern of deficits and vulnerabilities coincide with what we would understand as ARND. The other thing is, with this 4-digit code, given the different parameters, you can have a 1, 2, 3, 4, a 4, 4, 2, 1, a 4, 3, 1, 2. You can basically come up with 256 combinations of patterns. And those are sort of simplified into 9 diagnostic categories. And so that can make it a little bit daunting to use. And in terms of if what we're also trying to do is to create a greater awareness of what a child's deficits and needs are, sometimes the nomenclature can be a little difficult. So if I said, well, your child has static encephalopathy, alcohol exposed with neurodevelopmental vulnerabilities, and a neurobehavioral disorder, that's kind of a mouthful. And so it is, I am not sure, whether that descriptor of terms, even though it's trying to be very precise in what the needs are, whether that can communicate to families, to providers, to therapists, to the school systems, to the juvenile justice system in a very concrete way what a child needs. So something to think about. In 2004, the CDC came up with their own guidelines. The only diagnosis that they have provided diagnostic criteria for is FAS, with or without confirmed alcohol exposure. The criteria they've delineated are very similar to the University of Washington: growth deficiency, height or weight less than the 10th percentile, full facial features requiring palpebral visual lengths of less than 3 and a lip infiltrum of 4 or 5. So again, very similar to the University of Washington criteria. This is where they diverge from the University of Washington criteria. The CDC describes CNS dysfunction as a head circumference less than 10%, as opposed to Washington that says less than 3%, and either hard neurologic signs or some pattern of CNS dysfunction, so 3 areas of deficit, 1 standard deviation below the mean, or an IQ more than 2 standard deviations below the mean, so an IQ of less than 70. And again, they quantify prenatal alcohol exposure. The CDC criteria were developed by the CDC to really try to provide a standardized assessment, a standardized diagnostic criteria for the assessment of FAS. But the vulnerability of this system is that it only looks at FAS. It does not include partial FAS, it does not include ARBD, it does not include ARND. After the CDC guidelines came out, then we had the Canadian guidelines, who came up with their own set of criteria. So I hope you can appreciate the complexity of all of this. The diagnostic disorders that are defined by the Canadian guidelines are FAS, partial FAS, and ARND. They have similar guidelines: growth deficiency, height or weight less than the 10th percentile, or weight for height ratio less than the 10th percentile. Their facial features are a little bit different from the CDC guidelines and from University of Washington. They say you can have 2 to 3 facial features: small palpebral visual lengths less than 3% and a lip infiltrum of 4 or 5. So there's some consistencies and some differences. They describe the CNS dysfunction not in terms of microcephaly, but in terms of functional impairment, and they say 3 areas of impairment, which they've described as more than 1.5 standard deviations below the mean, and evidence of prenatal alcohol exposure. The advantages are the CNS deficits are adjusted to account for developmental levels. So for young children, and we'll talk about this later in the talk, for young children under 6, you only have to have 2 areas of deficit instead of 3. The disadvantage of this system is that they have normative values that are based on North American populations, and they don't include ARBD, alcohol-related birth defects. And so finally, we get to the last criteria, which is the revised Institute of Medicine criteria. They really took the original Institute of Medicine criteria and tried to provide a little more diagnostic clarity and a little more precision regarding what these cutoffs were. And so those 4 diagnoses were really expanded to 6. Fetal alcohol syndrome with or without alcohol exposure, partial fetal alcohol syndrome with or without confirmed alcohol exposure, alcohol-related birth defects, alcohol-related neurodevelopmental disorders. Their diagnostic criteria, similar yet different, growth deficiency, height or weight less than the 10th percentile, height ratio less than the 10th percentile, facial features. So unlike the other criteria, which require 3 facial features, in the Revised Institute of Medicine, you can meet FASD if you have 2 facial features. They look at CNS dysfunction as a head circumference less than the 10th percentile, so not less than the 3rd percentile like Washington, and some complex pattern of behavior or cognitive deficits, which is not well defined. They list these different areas of impairment, so visual spatial awareness, attention, self-regulation, metacognition, social deficits, but a cutoff is not defined. And then again, prenatal alcohol exposure is explored. The advantages of this system is that it quantifies the Institute of Medicine's criteria for CNS deficits. It describes in greater detail what the patterns of ARBD are. It considers, in terms of a differential diagnosis, the possibility that these patterns of facial anomalies, this pattern of unique differences, can be accounted for by other conditions such as genetic disorders. The limitation of this system is, again, the normative values are based on North American populations, and this is not a widely disseminated diagnostic classification system. I think the other advantage of this is because it built on the Institute of Medicine, there are very clear diagnostic categories, and so it's a little bit easier to conceptualize and to understand. And so just to highlight, I don't know that you can see this slide because the print is so small and I'm so sorry, but basically what you would see if this projected a little bit better is that in terms of growth, you have a lot of similarities in terms of most of these are saying less than the 10th percentile for growth. In terms of facial features, you have some differences, whether you need 2 facial features or 3 facial features. Regarding CNS deficits, there's some variability. Do you have a head circumference less than the 3rd percentile, a head circumference less than the 10th percentile? How do you quantify those CNS deficits? Is it 1 standard deviation below the mean, like the CDC says? Is it 1.5 to 2 standard deviations below the mean, like the Canadian guidelines say, or is it just some complex pattern of malformations and conditions, and what does that mean? And then regarding alcohol exposure, is it enough to just say that mother drank, or should it be quantified? So I think there's a lot of complexity, which I think basically this leads us to this big question. There are many classification systems which I think at some level create more questions than answers, especially for those of us in the field and those of us who are in the front lines. And so I present all of this not because I have any answers, but because I think it's important for us to start thinking and dialoguing about, as we're putting systems in place, how do we think about our criteria, our classifications of how we're identifying individuals.